Students, so in today's video we are going to discuss about Liddle syndrome, means the pathophysiological mechanism of Liddle syndrome, how exactly Liddle syndrome occurs, why it occurs, right? And what are the different clinical features of Liddle syndrome, right? And through Liddle syndrome we are going to understand how exactly this chain reaction of events work, right? Once you understand these subsequent chain reactions, you're going to actually enjoy the whole process, that how exactly one thing leads to another, then that thing lead to another, right? So it's an interesting mechanism, and we are going to study about Liddle syndrome in detail, right? So let's start, right? So what exactly is the problem in Liddle syndrome, right? In Liddle syndrome, the issue is in our collecting duct, right? Collecting duct. In collecting duct, we have got P cells, right? And in P cells, we have got channels called ENaC channels, right? Which channels? ENaC channels. Now, anything can have two kind of mutations, right? Loss of function mutation or gain of function mutation. In loss of function mutation, that thing doesn't works at all, right? In gain of function mutation, the functionality of that thing actually increases, right? Now this ENaC actually consists of three subunits, right? Alpha, beta, and gamma, right? Three subunits, alpha, beta, and gamma, right? And all these three subunits are actually coded by different genes, right? SCNN1, right? This is the common starting name, and after that we can have A, we can have B, we can have G, right? This SCNN1A will code for alpha, the B1 will code for beta, the G1 will code for gamma, right? So what actually happens in Liddle syndrome, right? This ENaC channel is being continuously synthesized and degraded, right? But in Liddle syndrome, right, due to a reason which we are going to discuss, the degradation of this channel stops, right? So this channel will get synthesized, but it won't get degraded, right? Now why it doesn't get degraded, that we are going to discuss. Now this ENaC channel actually needs ubiquitin for its degradation. To be specific, it needs E3 ubiquitin ligase, right? It needs E3 ubiquitin ligase for its degradation, right? E3 ubiquitin ligase, right? Another name for this is N E double D 42, right? Both these are names of same compound. It goes and binds. It goes and binds where? It goes and binds with the PY motif, right? PY motif. We also call it proline rich PY motif, right? Where it is situated? At the C terminus end of these two units, beta and gamma, right? Proline rich PY motif at C terminus ends of beta and gamma. Now what will happen in Liddle syndrome is that this PY motif won't be there, right? This PY motif gets mutated. Now think of it, right? This E3 ubiquitin ligase needs to go and bind to this PY motif to degrade this ENaC channel, right? Since this PY motif will be degraded, it won't be able to bind. So your ENaC channel is going to survive longer, right? So your ENaC channel won't be degraded. Now, if this ENaC channels doesn't get degraded, then what is going to happen, right? Then you have sodium ions inside your collecting duct, right? This ENaC channels are going to reabsorb sodium, right? And what we have learned, that wherever sodium goes, the water follows. So if this ENaC channel persists and they reabsorb lot of sodium, the water is also going to follow. So lot of reabsorption of water, right? Sodium is coming, water is coming behind it, and this starts a chain reaction which we are going to discuss, right? So more sodium, more water, so what it will lead to? It will lead to increase in ECF, right? ECF will increase, right? If the ECF volume increases, right? Suppose you have a lot of water inside your body, right? So of course the venous return going to the heart will increase because there is a lot of fluid inside the body. The venous return in the heart will increase, right? So the end diastolic volume will increase. Your heart, which is relaxing, gets more blood. So Frank-Starling law, the stroke volume will increase. If stroke volume increases, right, your cardiac output will increase and your blood pressure will increase, right? So ECF volume will increase, then venous return will increase, right? And due to Frank-Starling law, the stroke volume will increase, and ultimately it will lead to increase in blood pressure, right? Now write all the basic points over here, and then we will further extend those chain reactions, right? Now blood pressure is increasing, right? Apart from that, the sodium is coming, so we can write hypernatremia, right? Sodium is increasing, hypernatremia. Right? Apart from that, suppose the sodium goes from this end to this end. So positive charge is going outside. Positive charge is moving away. So the inside of this collecting duct will become negative, 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 right? The inside will become negative, right? And this is going to pull potassium outside, right? So potassium will come into the collecting duct. Sodium will go out and potassium will come in. And this potassium will be excreted out in the urine, right? And if this potassium gets excreted out in the urine, what you will get? We will get hypokalemia, right? Hypokalemia. Right? First thing, sodium is coming out into our blood vessels from the collecting duct. So we get hypernatremia. Potassium is coming into the collecting duct and getting excreted out in the urine. So it will cause hypokalemia. Now, one very important thing over here is that the potassium is very precious ion for the body, right? Potassium is a very critical ion for the body. Body tries to regulate potassium between two very narrow ranges, right? So body will do everything to preserve this potassium which is going out, right? So those intercalated cells, right, they will try to reabsorb this potassium, right? But while trying to reabsorb this potassium, they have to excrete out H plus ion. They will reabsorb potassium and excrete out H plus ion, right? And this will lead to alkalosis, loss of H plus ion. This will lead to alkalosis. There's also one very important reason of alkalosis is that in any normal blood vessel, right? In any normal blood vessel, suppose this is a cell, you have got an antipode which transports K plus into the blood vessel and transport H plus inside, right? So in case of hypokalemia, right, this is K plus. So in case of hypokalemia, what will happen? More K plus will enter from the cell into the blood vessel, but more H plus will enter into the cell. K plus will go from cell into the blood to buffer out, to compensate for the hypokalemia, right? This potassium will become normal, but this H plus will come on. So what you will get is basically alkalosis, right? Here we have got less potassium, right, in blood. So this potassium will come into the blood, but H plus will come into the cell. So you get alkalosis. Two reasons for alkalosis. One reason is that potassium is a very precious ion for the body. So intercalated cells will reabsorb potassium, but they have to excrete out H plus ion, right? So this will lead to alkalosis. Other reason is you got K plus H plus antipode in all your cells. So in case of hypokalemia, the K plus will go into blood in exchange of H plus, which will go inside the cell. So less H plus in the blood, this will also lead to alkalosis, right? Now let's carry on forward with our chain reactions, right? Now blood pressure. What blood pressure can further lead to, right? The blood pressure can further lead to headache. Yeah, most common symptom in blood pressure, it can lead to headache, right? What else it can lead to, right? Apart from headache, it can lead to retinopathy, right? Hypertensive retinopathy, right? What else it can lead to? It can lead to left ventricular hypertrophy, right? LVH, in short form I can write. Left ventricular hypertrophy, headache, retinopathy, left ventricular hypertrophy. What else? It can damage kidneys, so it can lead to chronic kidney disease, right? Chronic kidney disease we can write. And what chronic kidney disease can lead to? It can lead to proteinuria, right? Proteinuria. Right? First of all, headache, retinopathy, left ventricular hypertrophy, right? And chronic kidney disease leading to proteinuria. Left ventricular hypertrophy can further lead to arrhythmias, right? Though there are other reasons for arrhythmias in this Liddle syndrome, the hypokalemia, right? And now, what hypernatremia can lead to, right? This hypernatremia, right, can suppress your RAS system, right? It is going to suppress the RAS. It is going to suppress your RAS system. So it is going to also suppress your angiotensin 2, right? And it is also going to suppress what? Aldosterone, right? So this is one of the reasons why Liddle syndrome is also called pseudo hyperaldosteronism. While Liddle syndrome is called pseudo hypoaldosteronism, pseudo hyperaldosteronism, because if you see these two things, these three things, in fact, hypernatremia, hypokalemia, and alkalosis, right? If you just focus on these things, right, you will feel as if aldosterone has increased. Aldosterone does these things. It increases blood pressure, it causes hypernatremia, it causes hypokalemia, it causes alkalosis. All these three or four things are done by aldosterone, right? But in case of Liddle syndrome, the aldosterone is actually less, right? That's why Liddle syndrome is also called pseudo hyperaldosteronism, right? Let me write at the very top. Okay, Liddle syndrome is also called pseudo hyperaldosteronism. Okay, now what else? Let's move our chain reaction further, right? Now, one very important thing which we can see is our very critical ion, hypokalemia, right? Now, what hypokalemia can do, right? The hypokalemia can lead to muscle cramps, it can lead to constipation, it can lead to fatigue, right? But one very important thing hypokalemia can do is it can cause polyuria, right? Now this is something very interesting, right? If you see this, the sodium is coming, and at the back of it, water is coming, right? So what do you think? What can happen in case of Liddle syndrome? You will think that Liddle syndrome causes oligouria, right? But that's not the case. In Liddle syndrome, you get polyuria, right? And that polyuria is because of the hypokalemia that we see in Liddle syndrome, right? So why exactly polyuria happens in Liddle syndrome? We'll see, right? This hypokalemia, right? This is going to reduce, this is going to actually, first of all, increase your prostaglandins, right? The prostaglandins in turn will reduce the level of adenyl cyclase, right? And this will further reduce the level of cyclic AMP. And if you can recall our previous video in which we saw the mechanism of action of antidiuretic hormone, right? How it works? Antidiuretic hormone acts on B2 receptor. B2 receptor in turn stimulates your adenyl cyclase, right? This adenyl cyclase converts ATP into cyclic AMP. This cyclic AMP in turn activates the protein kinase A, which causes the recruitment of aquaporin to channels, right? So increase in level of adenyl cyclase, increase in level of cyclic AMP, increase in level of protein kinase A is important for recruitment of the aquaporin to channels. But this hypokalemia does just the reverse thing. It increases the level of prostaglandins, which reduces the level of adenyl cyclase, which reduces the level of cyclic AMP, and it will reduce the recruitment of aquaporin to channels. Of, let me write in short form, AQP2, aquaporin to channels, right? For others, we can write over here, hypokalemia, what it can lead to? It can lead to muscle cramps, it can lead to fatigue, right? It can lead to constipation, right? There is one very peculiar thing about increase in blood pressure of Liddle syndrome. That peculiar thing is that it is treatment resistant, right? Here, what is the main pathology? The ENaC channels are not getting degraded, right? Now, if you give any drug in this Liddle syndrome, be it captopril, what captopril will do? It will reduce the level of angiotensin 2, it will reduce the level of aldosterone, but aldosterone level is already low, right? So captopril won't work, right? Any angiotensin 2 receptor blocker, losartan, telmisartan, even those drugs won't work, right? Because aldosterone level is already low. The issue is not aldosterone, issue is the ENaC channel itself, right? So only drug which actually works in this Liddle syndrome is your amiloride, because amiloride directly goes and inhibits this ENaC channels, right? So what we call this blood pressure is basically treatment resistant and salt sensitive. Now, if you take less salt, you will have less sodium to get reabsorbed. So that will be effective, right? Treatment resistant, salt sensitive, and early onset, right? The onset is early. If this is the problem, you will have hypertension from the childhood itself, right? So early onset, treatment resistant, and salt sensitive hypertension, we can say, right? So if we write early onset, salt sensitive, and treatment resistant, apart from, of course, your amiloride. Right? And which is the only drug which can act on this and help is your amiloride. Okay. Now let's further continue with our chain reaction, alkalosis, right? Now what alkalosis can lead to, right? It doesn't normally leads to, in rare conditions, I will say, right? What alkalosis can lead to is tetany. So alkalosis has to be of certain severity to lead to tetany, right? So how alkalosis can lead to tetany, right? Now let's recall, in our previous video, we discussed alkalosis. Alkalosis means what? Less H plus ion, right? Less H plus ion in plasma. If we have got less H plus ion in plasma, the blood will ask of more H plus ion. From which protein? It will ask it from albumin. So alkalosis has happened, blood has got less H plus ion, and now it asks for that extra H plus ion from albumin, right? Now albumin has got common binding site both for H plus ion and calcium ion, right? So it will take H plus from albumin and those sites will become vacant and they will be occupied by calcium from the plasma, right? So now the blood will have hypocalcemia, right? Now we have got less calcium to exert that calcium clamp effect on the sodium ion channel. Now sodium ions can easily enter into those sodium ion channel, right? If they easily enter inside the cell, inside those nerve cells, then rapid depolarization will happen. Your nerve cells, your nerves will become more excitable. More excitable nerves means tetany, right? So in case of severe alkalosis, you will get tetany, right? So many things. It starts with one simple ion channels and you get a whole plethora of clinical signs and symptoms, right? So let's sum it up, right? So what exactly goes wrong in Liddle syndrome or pseudo hyperaldosteronism, right? The ENaC channels get gain of function mutation, right? It has got three subunits, alpha, beta, and gamma, right? What goes wrong is that this PY motif gets deleted. When this PY motif gets deleted, the E3 ubiquitin ligase can't bind with the ENaC channels. So the ENaC channels won't get degraded. The ENaC channels are going to survive longer. If they survive longer, more sodium will come inside. If more sodium come inside, the more water is going to follow it. If more water follows it, then what you will get? You will get more ECF volume. If ECF volume increases, if there is more fluid inside your body, the venous return will increase, right? Frank-Starling law, stroke volume will increase. So the systolic blood pressure, your BP, is going to increase, right? What else can happen? Because sodium is coming, so hypernatremia is going to happen, right? If more sodium goes out, the inner lining will become negative, the potassium will come in, right? Sodium goes this side, the potassium will pull the potassium inside, right? So this potassium will get lost and we will get hypokalemia. Body will try to preserve this potassium, the intercalated cells, but will end up excreting H plus ion in the process of trying to preserve this potassium. If this H plus ion gets excreted out, you will get alkalosis, right? What this blood pressure can lead to? It can lead to headache, it can lead to retinopathy, it can lead to left ventricular hypertrophy, and it can lead to chronic kidney disease, right? And what hypernatremia can lead to? The hypernatremia will suppress your RAS system, will suppress your angiotensin 2, right? And it will suppress your aldosterone. Aldosterone is actually low. That's why it is called pseudo hyperaldosteronism, because it has got all the symptoms of hyperaldosteronism with low level of aldosterone, right? What hypokalemia can lead to? Hypokalemia can lead to muscle cramps, constipation, fatigue. But one very important thing hypokalemia can lead to is polyuria, and that is by increasing the synthesis of prostaglandins, which decreases the level of adenyl cyclase, which decreases the level of cyclic AMP, right? Which reduces the recruitment of aquaporin to channels, right? And alkalosis in severe cases can lead to tetany, right? So hopefully this video help you in developing a conceptual understanding of the chain reaction in case of Liddle syndrome. Wish you all the very best. Thank you.